Cervical radiculopathy is a condition that often brings patients to the clinic with complaints of neck and arm pain, tingling, or weakness. However, not all symptoms that look like cervical radiculopathy are actually caused by nerve root compression. In fact, a significant number of patients with suspected cervical radiculopathy actually have musculoskeletal disorders that mimic these symptoms. Understanding the difference is crucial for accurate diagnosis and effective treatment. In this video, we'll explore the various musculoskeletal conditions that can imitate cervical radiculopathy, why they matter, and how clinicians can distinguish between them for better patient outcomes. It's not uncommon for patients to feel frustrated when their test results for cervical radiculopathy come back normal, despite ongoing symptoms. This is because musculoskeletal mimics can present with similar pain patterns, leading to confusion and sometimes unnecessary treatments. Recognizing these mimics can help reduce the time between symptom onset and the right diagnosis, ultimately improving patient care. Moreover, cervical radiculopathy and musculoskeletal disorders can coexist, making the clinical picture even more complex. That's why a thorough understanding of these mimics is essential for healthcare providers. Musculoskeletal mimics originating from the head and neck can closely resemble cervical radiculopathy, especially lesions affecting the C1 to C6 nerve roots. Common examples include tension neck pain, cervicogenic headaches, and temporomandibular disorders. These conditions often present with neck pain, tenderness to touch, and sometimes headaches that radiate to the ear or upper back. Unlike true radiculopathy, these mimics may not follow a specific nerve root distribution and often improve with targeted injections or physical therapy. Recognizing these patterns helps clinicians avoid misdiagnosis and unnecessary interventions. Shoulder problems are a frequent source of symptoms that mimic cervical radiculopathy. Conditions like rotator cuff tears, impingement syndrome, and adhesive capsulitis, also known as frozen shoulder, can cause pain and weakness that radiate to the arm. These symptoms can be mistaken for nerve root issues, especially when pain worsens with overhead activities or at night. Clinical tests such as Neers and Hawkins can help identify impingement, while imaging and targeted injections can further clarify the diagnosis. Understanding these shoulder-related mimics is key to providing the right treatment. Pain in the elbow and forearm can also resemble cervical radiculopathy, particularly affecting the C6 to C8 nerve roots. Lateral epicondylitis, commonly known as tennis elbow, and medial epicondylitis or golfer's elbow are typical examples. These conditions often result from repetitive tasks and present with pain during wrist and finger extension or flexion. Forearm compartment syndrome and swelling can further complicate the picture, sometimes leading to hand weakness and paresthesias. Differentiating these from nerve root problems requires careful clinical examination and sometimes imaging. Wrist and hand conditions such as de Quervain's tenosynovitis and intersection syndrome can mimic symptoms of cervical radiculopathy in the C6 to C8 distribution. De Quervain's affects the thumb tendons, causing pain on the radial side of the wrist, while intersection syndrome involves the crossing of wrist extensor tendons and presence with pain and swelling on the dorsal forearm. These conditions are often differentiated by specific clinical tests such as Finkelstein's test for de Quervain and by their response to local treatments. Muscle and connective tissue disorders such as myofascial pain syndrome can also imitate cervical radiculopathy. Myofascial trigger points or muscle knots often cause referred pain that doesn't follow a specific nerve root pattern. These trigger points can be found in the neck, shoulder, or even distant muscles, and are often associated with tenderness and a jump sign when palpated. Imaging techniques like ultrasound elastography have helped visualize these trigger points, supporting their role in musculoskeletal pain syndromes. Biomechanical imbalances and changes in range of motion (ROM) can contribute to symptoms that mimic cervical radiculopathy. Poor posture, such as forward head tilt and rounded shoulders, increases strain on the neck and shoulder muscles. This can lead to muscle overuse, contractures, and even secondary nerve compression. Decreased ROM, as seen in frozen shoulder, or increased joint laxity, as in Ehlers-Danlos syndrome, can also produce pain and weakness that resemble nerve root problems. Addressing these biomechanical issues is an important part of comprehensive care. Vascular conditions like thoracic outlet syndrome, TOS, and autonomic disorders such as complex regional pain syndrome, CRPS, can also present with symptoms similar to cervical radiculopathy. TOS involves compression of blood vessels or nerves in the neck and shoulder region, leading to arm pain, numbness, and sometimes color changes or swelling. CRPS is characterized by severe pain, sensory changes, and autonomic dysfunction, often following trauma. These conditions require specific diagnostic tests and imaging to distinguish them from nerve root pathology. Distinguishing musculoskeletal mimics from true cervical radiculopathy relies on careful clinical evaluation. Key features favoring radiculopathy include muscle weakness, loss of reflexes, and sensory loss in a dermatomal pattern. In contrast, musculoskeletal mimics often present with pain that does not follow a nerve root distribution, tenderness to palpation, and symptoms that improve with local treatment. Diagnostic tests such as EMG, nerve conduction studies, and imaging can help clarify the diagnosis when the clinical picture is unclear. It's important to recognize that cervical radiculopathy and musculoskeletal disorders can coexist and even worsen each other. For example, muscle weakness from radiculopathy can lead to overuse of compensatory muscles, resulting in secondary musculoskeletal pain. Conversely, chronic musculoskeletal problems can alter posture and biomechanics, increasing the risk of nerve root compression. Effective management often requires addressing both conditions simultaneously to break the cycle of pain and dysfunction. Structured diagnostic approach is essential when evaluating patients with neck and arm symptoms. Start with a thorough history and physical examination, focusing on the pattern of pain, associated symptoms, and any aggravating or relieving factors. Use specific clinical tests to assess for musculoskeletal conditions and nerve root involvement. When necessary, order imaging studies or electrodiagnostic tests to confirm the diagnosis. Collaboration with specialists in physical medicine, rheumatology, or neurology can be invaluable for complex cases. Management of musculoskeletal mimics depends on the underlying condition. Common strategies include physical therapy, stretching, strengthening exercises, myofascial release, and targeted injections. Addressing postural issues and ergonomic factors is also crucial, especially for patients with work-related symptoms. For inflammatory or rheumatologic conditions, referral to a specialist for disease-modifying treatments may be necessary. The goal is to restore function, reduce pain, and prevent chronic disability. Consider a patient presenting with neck and arm pain, initially suspected to have cervical radiculopathy. After a thorough evaluation, it's discovered that the true cause is a combination of rotator cuff tendinopathy and myofascial trigger points in the upper trapezius. With targeted physical therapy and local treatments, the patient's symptoms improve significantly. This case highlights the importance of considering musculoskeletal mimics and using a comprehensive approach to diagnosis and management. Summary: musculoskeletal mimics of cervical radiculopathy are common and can complicate the diagnostic process. Recognizing these mimics, understanding their clinical features, and using a structured approach to evaluation can help ensure accurate diagnosis and effective treatment. Remember, cervical radiculopathy and musculoskeletal disorders can coexist, so always consider both possibilities. By staying vigilant and informed, clinicians can help patients achieve better outcomes and avoid unnecessary interventions.